Okay, we're going to walk through the automation pathways here, starting with eligibility. And look, I know eligibility has been largely commoditized for years, so what should patient access be looking for to improve? Number one, for me, you got to start with your metrics. What are the core baseline of automation? What should you be expecting for automation by payer? What payers do not have any kind of automation, and why? Is this a mapping issue? Is it a payer doesn't support or supply that? Or could it be a supplier that needs to find a connection? There's lots of reasons why, but those metrics are really going to tell you that, what your automation rate not only is. So I look at it overall, what is the rate? And then really a subset of rejections, right? What is the reason for the rejection? Why do you have the rejection? So I've got the box to the right. I'll start there first. Depending on your payer mix, 85 to 95% of your total patient inventory, should be screened and fully automated. So, you're going to have, of course, we understand you have the TPLs, you have the work comp. That stuff is not going to be in an automated rate. But it is important that you understand what is our rate and what should we be driving to, and then the markets, of course, that we have and I work with day in and day out. We certainly get a very high range, and I'm going to walk through some of the strategies as to what you should be thinking about that. So one is mapping. Everything boils down to, your facility plan code, dictionary, if you will, and how many plan codes or how limited on plan codes you might be, but then how you're mapping those. So one thing to think about is that typically this sits in an IT-related space, and it should. But my team certainly got engaged and involved here in terms of helping to translate with the business when they're not getting the automation, understanding why. And then secondly, working with your IT partners that do the mapping, how to improve that rate. And there's so much opportunity in terms of understanding where those, where that mapping could be occurring or could be remapped or changed to get a better outcome. And if you don't have, as far as a strategy, if you don't have a regular cadence where you're connecting with those key folks that do the mapping for you, you should. If not bi-weekly, at least monthly, looking at the metrics, looking at the rejections, what opportunity by payer do we have? You'll also learn a lot about when payers are down for maintenance purposes. That's going to occur. You're not going to get a transaction at that point in time. That's certainly understandable. There's maintenance periods that occur, but this will help in terms of understanding, do you have opportunities, especially within the rejections, and you're not leveraging the eligibility automation because it plays into estimates, which we'll be talking about here in a little bit, and then authorizations as well. Service type codes. If you're not familiar with the service type code, this is a code that can often provide better details based on your service. So a service type code 30 is fairly typical, but you can expand within your automation. You can expand how, what types of service codes might prove to be more beneficial for you and getting the richest benefits for the purposes of estimation and for the purposes of communicating with the patient what they owe and why they owe it, right? So take a look at service type codes. Your suppliers, whatever the suppliers may be, can also help you with how those service type codes work and what options they have for you. Cascading is another great strategy that you should have and incorporate in your eligibility in terms of how requests are sent, and then how those requests, if they're rejected, might be able to be cascaded to what would be an appropriate payer. So think about cascading and how that eligibility could be maximized by not just accepting the rejection in your automated eligibility, but passing that on to maybe another payer that might be more appropriate. So that's certainly something to think about. We've got cascading throughout our organization, and certainly it's something that we leverage and get a lot of benefit from. Okay, data mining. This really gets into the quality. I think by and large, a 271 as it is, even if it's formatted and in a viewable, nice viewable format for the end user, you have the opportunity of taking that transaction and scrubbing it and relying on, what's essentially, going to be a good sized workforce, whether it's your patient access staff or your centralized teams or whoever it is that needs to read the eligibility and react and respond to it. An active response doesn't necessarily mean it's a right response. And it doesn't mean that you're good to go either. It doesn't mean that you don't have risk, right? So data mining comes in play, and we have a lot of RPA in this space to essentially read that 271, help the registrar understand what risk might be found in that 271, and then what should we do with that as a result. So for example, I'll pick an obvious one just to make it as relatable as I can. You're going to have an eligibility transaction, and if you have the data mining and RPA in place to read that 271 alongside with the registrar, we can certainly point out that, this traditional Medicare patient has an HMO, right? And so, what kind of stops can you put in place to keep that registration from going forward until they put in that Medicare Advantage plan? That's just one good example of some strategies that we've taken where even though the eligibility comes back as active, they're saying, hey, there's a problem here with this eligibility. We get that it's active and we've got our 271, we've got a response, but we need to do something differently with it. And too often I can see, our core audience, our registrars, where they take that response as good to go. And then you don't have it if you don't have any mining going on behind the scenes, and then prompting the end user to make a change based off of the data that we're able to pull out of that 271. That's going to lead to your eligibility denials, and we'll talk a little bit about that from a data perspective. And then lastly, don't forget about your audience. Your audience are your core registration staff. I've had the privilege of working with some of the smartest folks in the industry that really know registration well, but you also have a tendency to have some of these folks that are new that come in from other industries. So however you format your eligibility and provide that back to your core audience, which is the registrar, you need them to be able to take action and do something with that eligibility response, and really, is there some sort of behavior change you're also soliciting, right? Do you need them to update the account in your host system, whatever that is, and or change the plan code, or is it a limited benefit plan and you need them to take some sort of action? So there's lots of occurrences where that active eligibility doesn't mean a lot. And how do we relate that back to our audience, which is a registrar who really, or some sort of patient services representative who needs to interact either with the patient or with the payer and make some sort of change at that point in time so you don't end up with a denial downstream.